Welcome back to the endoscopic ear episodes. Our case today is an endoscopic retrograde enterotomy. Patient present with a recurrent ear infections, no obvious retraction in the attic, but there was like a kind of a bulgy appearance of the attic. A CT scan confirmed there is an attic erosion and cholesteatoma as well. We started as usual with the injection of the internal erythromeatus, elevation of the tympanomeatal flap. Reaching the annulus, as you can see, we started to elevate the annulus to explore the middle ear cavity. As you can see, the retraction in the attic there with we try to preserve the skin of the external erythromeatus as much as we can, but sometimes we need to remove some of the skin to get access and to get a wider space to work. We are dissecting the skin from the chorda tympani, and also the chorda tympani could be sacrificed if needed, if we find that it's in our way to remove the cholesteatoma. As we all know that this is a safe surgery if you get a wider and exposed area to work in. Otherwise it would be unsafe and you cannot work. So after removing the chorda to create a space, we also find that the incus was surrounded with the skin, so we removal of the remaining of the incus as the short process and part of the body has been eroded by the cholesteatoma. Again, this is the tensor tympani, so we cut the tensor tympani to create more space, and as you can see, the head as well is surrounded with the cholesteatoma, so get the bone nibbler and removal of the head as well to see the skin behind the bone in the attic area. Okay, this is just the remaining of the chorda tympani. So I'm checking the facial nerve. It was on the scans are intact, but as well there is a bony intact here. And from now we will try to dissect the cholesteatoma in the attic area, the anterior and the posterior bit tympani, to see how much extent that we can remove a trans canal. Sometimes we need to go and drill from behind, but in this case it was really retracted mastoid or contracted mastoid, so there isn't much space for drilling. So that's why we decided to go for the retrograde from transcanal with the endoscopy. And again, dissecting the cholesteatoma. Thomson dissector are one of my best friends in those angle areas. So just dissecting the mucosa over the fissure nerve. Again, in the anterior epitympana. Sometimes you need to take it piecemeal, just to have a wider area to work in. In this case, we found that the myotoplasty as well was helping, as there is no space in the upper part of the ear canal. So you can do this kind of a myotoplasty, just cutting the skin of the external auditory meatus. Sometimes you need to remove a bit of the skin as well, so like what we have done, just trim small piece of the skin to widen the area of work. And you can see now we have a good space for drilling. And from now, I usually start with the curate, just to not really to curate with, but more likely to feel the areas surrounding, and what is the depth as well. It's mainly for measuring the depth, and then later you can start the drill. I used the largest drill first, so I started with the try first the 3 millimeters, and then the 1.5 millimeter cutting bare. It's not easy to drill inside the canal, but it's, to be honest, there is no much bone there, so it's a bit of hectic that you just drill and suck, drill and suck. The second bit is that you need to change the position of your scopes as well. So this part of the myotoplasty that was said before, you can remove a bit of the skin as well if it's interfering with your drill. Okay. And you need to move around to change the position of your scopes. This is very important. I try not to do a bit of a montaging for this, despite it's a bit annoying for the suction and the clearing of the scopes, but this is to show you how it's difficult to drill inside. In the same time, if you train to handle the scopes and the drill, it's not that difficult. Important to protect your fissure nerve, which is the important structure here. Otherwise, it's safe. And again, with the curate, the aim of the curate is not really to move the bone, more than feeling how much depth that behind as well, or left behind. And then with the Thomson to remove the sac, the area of the dome of the lateral semicircular canal. In most of the cases, if I find that the cholesteatoma is extended beyond the dome of the lateral semicircular canal, I do a transmastoid cortical mastoidectomy rather than transcanal. But as I said, in this case, it was mainly a very contracted mastoid, sclerotic there, so there isn't much of an aerated cells at the tip. So keep drilling, try to get as much from the ear canal bone. It's like what you do in the retrogrades, and reconstruct the ear canal later on. So I skipped part of the drilling, but I kept drilling there just to reach to the end of the sac. And so we remove the sac and the most posterior bit of it, which is this part. And you can see that's it's almost clear there, but we need to make it more smoother so we can reconstruct easily in the attic area. Okay, and once we cleared up the cholesteatoma sac, you can see that the rest cells was full of thick gluey tissue, which is being cleared up with the rinsing up the nose. Curved suction is very important as well to reach to the depths of what you can see. And just keep drilling until you sussurize it nicely, make it more smooth. And you can see this is, again, changing the position is important. Also make sure that you remove all of the bony debris from the middle ear cavity. And the same, just keep drilling until you make it nice smooth cavity there. And just any of those mucosal thickening could be removed as well. This part is for my trainee. She was trying to drill, so just to see how much it's difficult to position the scope and the drill, just to do a little bit of a smoothing of the remaining bone there. But it's a learning curve at the end. And again, some people ask, well, if you remove the cholesteatoma, why trying to drill more of the bone? So the important just to not only to make sure that you what you can see is doesn't have a cholesteatoma, but also you need to confirm that you're happy that there is no left skin behind as well. So And the next stage will be the 30-degree scope. Just to make sure, this is the just mucosa over the semicircular canal, the lateral semicircular canal. And now I'm using the 30-degree to go in after cleaning and washing, just to make sure. And you can see that it's almost the mastoid is contracted and or sclerotic, so it's not that much of an air cells behind. And also in the corner. So this is the 30-degree. Back again to what is the next. So we have a nice smooth small cavity. Reconstruction is the aim now. We preserve as much as we can from the skin. This patient have a good hearing, which is due to the cholesteatoma bridge. So we decided to go for a probe for him to help him for hearing. I tried to use one of the metallic titanium prostheses, but seemed to be it wasn't that making much good, as there is no much bone support. So I decided to go for the fluoroplastics one, which seemed to be it works well. It was nicely in position. And then the next step is to reconstruct the attic and the tympanic membrane. Make sure that if you're using the fluoroplastic, to have a good thick cartilage to support over the prosthesis, as there is an early extrusion of those fluoroplastic, this is one of the side effects of them. But if you use the cartilage, usually they remain inside and they do their job well. Again, to show you that it's not easy to reconstruct, especially if you're single-handed with this scope. But it's just the positioning of the cartilage. You need to sometimes use different layers or double layers of a cartilage and a perichondrium to make sure that everything is in position. Make sure your prosthesis as well is good. So in this case, I've cut the cartilage to 2 pieces, just to get a good support to the prosthesis in position. In this case, I've retained back the skin of the attic back again, and the tympanic membrane skin, and then an extra layer of a perichondrium could be underlay or overlay. Preferred to be underlay rather than the overlay. So pulling the skin now, it's free because we have already cut the tensor tympani, so we have a good space there. So I put the cartridge to support anteriorly and a small piece of the posterior part of the tympanic membrane to support the prosthesis. And again, the advance of the scope is just to visualize all of your action directly, and the disadvantages that you're single hand used. So you need to use only one hand, which is kind of difficult. But again, training is the most important part of it. So now, everything is in position. Back again, the skin. So once I measure it, I found it's a good position. Everything is back, so a nice piece of perichondrium can cover parts of sites of reconstruction, which is the tympanic membrane and the attic area. we use the tragal cartilage, and you can see you can get a nice large tragal cartilage, and depend on your assistant as well. So usually he's the one who took the cartilage, so make sure that he's taking a nice large one piece of cartilage if you gonna reconstruct. And a little bit of this pericondium back to the external ear canal, because we have cut or trim a little bit off the skin as well, and then adjust it to the end of it. Try to pull your cartilage to, and your pericondium to the end of it. Sometimes you need to trim some of pieces of the skins, like what we have done, to make sure that the pericondium is covering the whole area. Back again with the gel foam to support your reconstruction, and close the ears as usual with either the ribbon goes with some antibiotics ointment, PEP if you want, or just the ointment directly. Depends on the case, to be honest. In this case we put a ribbon gauze, but most of the cases we don't put any ribbon gauze there, just the ointment inside the ear canal will be enough, as we didn't remove much from the cartilage, and we did immobilize the most of the external auditory canal. And thank you for watching the endoscopic ear episodes.